The following podcast is part of a certified educational activity titled Making Connections to Improve Patient Care in Obesity, Metabolism, and Liver Health. Access the entire activity and complete the post-test at peerview.com/GPQ860. Downloadable slides and practice aids are also available.
My name is Arun Sanyal, and I'd like to welcome you to this session supported by PeerView and entitled Making Connections to Improve Patient Care in Obesity, Metabolism, and Liver Health. So what we're going to do this afternoon is describe this condition called metabolic dysfunction-associated steatotic liver disease, which is a mouthful. I'm just going to call it MASLD. And its variant MASH, and obesity, and really the role of metabolic dysfunction, chronic inflammation. Try and identify which patients in your practice might have this, and which ones you should really be concerned about. How do you find them, and what do you do about them, and what are the emerging therapeutics for this? So that's our goal for today. So MASLD has emerged as a condition which was originally described by liver pathologists where patients had excess fat in their liver, looked like alcohol-related liver disease, but clearly were in patients who were not consuming alcohol. So it used to be called non-alcoholic fatty liver disease. And over the course of the last 20 years, there has been an evolution where we now realize that the underlying basis is metabolic and closely linked to obesity as well, and thus the name change to metabolic dysfunction-associated steatotic liver disease. And at least in the English language, the word fatty is considered stigmatizing, so we moved away from that word, and so it is now MASLD. The reason we talk about this is metabolic dysfunction-associated steatohepatitis, or MASH, is more likely to progress to cirrhosis. And so that's sort of the spectrum of the liver disease. Now, if you go to the right of this slide and you go from the general population to those who have steatohepatitis, you see there's a substantial enrichment of the prevalence of obesity, type 2 diabetes, hypertension, hypertriglyceridemia, and full-blown metabolic syndrome, with about 70% to 80% of patients across different studies having full-blown metabolic syndrome. So this condition, highly prevalent in the kind of patients you are used to seeing. And this reflects the current classification of the system, where steatotic liver disease is a larger umbrella term, but we're really going to be talking today about the area in blue, which is metabolic dysfunction associated, and then extending now, understanding that some people also consume modest amounts of alcohol. They're not, consuming as so much alcohol that alcohol can be called the only cause of liver disease. So that it has now, the spectrum has been expanded, and this is called MET-ALD to recognize both the metabolic and the alcohol-related contributions. And it can be metabolic predominant or it can be alcohol predominant. So what we're going to talk about today is this roadmap. We'll first talk about the scope of the problem. First, why is it that we're even having this conversation? Why do we care? Next, we're going to sort of I'm going to present this idea or the concept which has emerged with the evidence of metabolic health through the lens of the liver, and then try to make the case of how we're moving from just organ-based approaches to more holistic, integrated approaches focused around metabolic health and metabolic medicine, which integrates all of these different organ diseases into the conversation. So if you look at the global burden of the disease, the global burden is about 30% of adult populations around the world, give or take in one country to the next. So about a third of the adult population has excess fat in their liver, and up to 5% have the more aggressive steatohepatitis lesion. And this is very tightly linked. If you were to overlay this on top of the similar graphs for obesity, diabetes, hypertension, you'll find they all look surprisingly alike. And as shown on the right, about 70 to 75% of obese individuals have excess fat in the liver, and the prevalence of MASH is almost a third in these. So while in the general population it's 5% for the steatohepatitis, the aggressive lesion, if you have risk factors like obesity or diabetes, that number can jump to 30 to 50 to 60%. So the aggressive lesion more likely when you have these metabolic risk factors. And when you look at the projection of disease of people who are now progressing towards cirrhosis and liver cancer, so we assess that through these fibrosis stages, depending on how scarred up the liver is, from F0, which is no scar, to F4, which is cirrhosis. And you see at the top in the US, there's a small fraction that currently has it. Most of the patients still are lower down where they have early stages of the disease. But when you look at the rates of projection in terms of muscle rates in association with type 2 diabetes and obesity, we're seeing a lot of people with advanced liver disease who are clinically silent, most of them, in those populations with high levels of obesity and type 2 diabetes. Okay, so very prevalent, rising burden of disease, rising number of people who are living with end-stage liver disease because of this condition. So now let's try to fit, where does this then fit in under the larger construct of obesity, cardiovascular disease, all the non-communicable diseases that we are familiar with. So if you look at the incidence data from the Centers for Disease Control, which is shown over here, what you see are three waves. The first wave is obesity, second is fatty liver, and the third is diabetes. So it's important to note that the liver disease actually is an early event. When you start gaining weight or your adiposity starts increasing, then you tend to put some fat in your liver, and that occurs quite early on. So now let's think about what does that actually mean for that individual. So let's look at first the clinical data, and then we'll talk about how this links to the biology of what's going on. So let's review the clinical data. So the first point here is that individuals with MASLD have increased metabolic health outcomes. So this is a paper that we did where we summarized 129 different publications with over 1 million people and identifying 32.4% of these populations having MASLD. And we found that those who have MASLD have increased metabolic health outcomes. So the hazard ratio for getting cardiovascular disease after accounting for all the other risk factors is 1.4. For hypertension, 1.7, diabetes, 2.5, and for full-blown metabolic syndrome, again, 2.5, CKD, 1.38, for cancer, 1.5. So as we think about non-communicable diseases as a group, which accounts for 70% of all premature deaths worldwide, anyone want to take a wild guess how many in that what that number actually is? The WHO estimates that at about 40 million people annually. 40 million premature deaths annually, more than all the terrorists, all the other bad stuff that's happening in this world is due to this cluster of NCDs. And this is critically linked to that process. Okay. Conversely, I hope that was convincing. Conversely, the more metabolic risk factors you have, the more likely it is that you will have actually a hard liver outcome. So when we talk about a hard liver outcome, we're now talking about developing ascites, encephalopathy, variceal hemorrhage, hepatocellular carcinoma, end-stage liver disease, eventually dying from this. So, and diabetes, among all these different metabolic risk factors, the two that are most linked to having a liver outcome are type 2 diabetes and hypertension. So your obese patient with hypertension, obese patient with type 2 diabetes, much more likely to have fat, not only fat in the liver, but steatohepatitis, not just steatohepatitis, but steatohepatitis with advanced fibrosis. And whether they're having symptoms or not, it's basically there. And that's the problem with this disease, is like hypertension, it will not let you know it is there unless you go looking for it. And just like in hypertension, you don't wait for a stroke before you decide to treat hypertension. This is a condition where you can prevent all those bad things from happening if you can get to the patient early. From a very liver-centric perspective, the outcomes are linked to how scarred the liver is. Imagine the liver going on a journey from normal to cirrhosis. Disease activity refers to how hard the liver is trying to run towards the destination, which is cirrhosis. So if you're driving a car, it's the RPMs on your dashboard telling you how hard the engine is trying to move you. On the other hand, disease stage tells you how far you've actually traveled on that journey. So it is the odometer. It tells you how many miles you have traveled. So the disease stage is linked to scarring of the liver, which is the consequence of the activity. Activity is the fat and the injury. Scarring is the outcome, and that is the fibrosis stage. More scarred, and you can see eventually stage 4, which is cirrhosis. There's a big jump. So development of cirrhosis is like a landmark event in the life course of these patients, after which all kinds of badness starts happening, but it really starts separating at fibrosis stage 3. Now, the causes of death at stages 0 to 2, which is early course disease, are largely cardiometabolic because the liver has a lot of reserve built into it. You only need about 10% of your liver to have relatively normal liver function. So the liver will not let you know something is wrong until it is very wrong. And at that point, you don't have much by way of treatment options. That's when we are having a conversation either about transplant or about hospice care. So that's not a good situation. We have a lot of opportunities to fix this. Okay, so the way I like to think about this then is like a metro line, where you start with fat. Fat injures the liver, you get steatohepatitis. That starts, and this I'm using the old nomenclature here. Then you start scarring down the liver, you get to cirrhosis, then you get to outcomes. And then that pretty much leads you to the cemetery, unless you can be salvaged. Like a metro line, you have to get off and get on a different line, but that's for 1% of the population. The other 99% end up in the cemetery. So in the first part of the disease, the risks, there's this whole concept of competing threats to life. Yes, there is liver disease, but in the relatively short term of 2 to 5 years, most of the risk in the early part of the disease is coming from all the surrounding badness from the cardiovascular disease, cancers, etc. But once you get to bridging fibrosis or stage 3, the lines flip. So that's when you start seeing liver-related outcomes becoming the primary cause of outcomes. And so it is different depending on where you are in the course of the disease. So I've gone through this clinical data summarizing that more liver disease, more metabolic disease, more metabolic outcomes, and MASLD after addressing all the confounders. So they're very closely interlinked. Now let's talk about the biology. What does the fat in the liver have to do with diabetes or all this other stuff? So it really goes back again, and this is germane for our obesity meeting, to visceral adipose tissue and inflammation of visceral adipose tissue and the development of insulin resistance, where visceral adipose tissue releases fatty acids, there's decreased adiponectin, it releases inflammatory cytokines like IL-6, etc. So the key consequences of this is insulin resistance and metabolic dysfunction. So many years ago, we did this study, which really got this whole MASH field going, where we did euglycemic hyperinsulinemic clamps in patients with fatty liver or with steatohepatitis. And what we show here, so this is a process for those who are not familiar, is where you start 2 IVs, one in each arm. In one arm, you infuse glucose, and the other arm, you infuse insulin. So you infuse insulin to get a steady state, and then you keep dialing up your glucose infusion till you can maintain normal, it's euglycemic, so normal blood sugar, but at steady state. So when the insulin level is at steady state, the sugar is at steady state. The amount of sugar you have to infuse to maintain that steady state of glucose is the amount of sugar being transported from the extracellular into the intracellular compartment, which is a function of insulin. And so the more sensitive you are, more sugar you have to infuse, less sensitive you are, less. So you can see a progressive stepwise decrease in insulin sensitivity from control to steatotic liver to steatohepatitis, both at low dose and high dose insulin infusion. So this first step that established a link between insulin resistance and steatotic liver disease, which used to be called fatty liver disease back in the day, then led to the linkage with diabetes, obesity, type 2 diabetes, and hypertension, and all the other stuff that has followed. And so how does this actually work? What does that have to, because insulin resistance is sugar. We just talked about sugar and insulin. What does that have to do with fat in the liver? So it has to do with this concept of metabolic flexibility. So when you are metabolically flexible, which is a healthy state, under fasted conditions, your circulating insulin levels are low. At that time, insulin is no longer suppressing lipolysis there's no insulin around to suppress lipolysis in your adipose tissue. So the adipose tissue releases fatty acids. Muscles take up the fatty acid and burn it primarily as a source of nutrition. And the liver's job is to make a little bit of glucose to feed the brain, because the brain doesn't like fat, it likes sugar. Okay. Now, when you eat, you get a surge of insulin. Insulin shuts off fatty acid release. Fat is taken up in adipose tissue. Sugar that you get from your food but the insulin pushes it into the muscle. The muscle knows now that it's not getting fatty acid, it's getting sugar. It flips. It moves from fatty acid to sugar as the primary source of energy. And this ability of the muscle to go back and forth and the body to react to substrate availability is known as metabolic flexibility. It is a lot of literature from particularly in the athletics field to promote this so that people can have absolutely the maximum amount of ATP that they can have to be good athletes. Now, when you get insulin resistant, you basically have high levels of insulin all of the time. And at that point, what happens is that instead of getting this nice curve of high level of insulin, low level, it's all high and doesn't fluctuate much. The adipose tissue is resistant to the insulin effects on suppressing lipolysis, so it's continuously leaking fatty acids. The muscle can take up the fatty acid but is unable to burn the fatty acids. And because of insulin resistance, you cannot clear glucose. So where is all this excess fat going to go? It goes back into adipocyte or it goes into the liver. Liver is the next organ that takes it up. And similarly, the excess glucose, liver takes it up. And the liver, through this process called de novo lipogenesis, can convert that excess glucose into fatty acids. All of this lead to a triglyceride load in the liver. So this is how insulin resistance, which originates in adipose tissue, creates this glucose dysmetabolism and fatty acid dysmetabolism, results in excess sources of fuel that get converted into fatty acids and triglycerides in the liver. So now that we've talked about how you deliver excess sugar and fat into the liver and convert it into excess triglyceride, and how does that result into steatohepatitis? So what happens is basically this 4-step process where you deliver this lipotoxic load along with inflammatory cytokines from the adipose tissue. This basically creates a metabolic stress for the liver cells. If cells are stressed enough, they die. And the injury to the cells triggers an inflammatory response, which then leads to a fibrotic response, ultimately culminating in cirrhosis. And there are specific steps along the way. Remember, we talked about disease activity and stage. The first 3 steps are linked to disease activity, and the last one to disease stage. Now, nothing actually turns out unique about this pathophysiologic cascade, because if you look at heart failure with preserved ejection fraction and islet cell loss, much of the same biology of lipotoxicity, glucotoxicity, cellular injury, apoptosis, ferroptosis, necroptosis, activation of the innate immune system, role of the inflammasome, chronic inflammation driving a fibrogenic response, all of these are in play. So basically, these conditions are connected by common biology. And hopefully now we have connected the dots all the way from adiposity to adipose tissue inflammation, loss of metabolic flexibility, development of insulin resistance, delivery of fat in the liver, production of more fat, injury to the liver, and how that eventually leads to scarring. And if you look at atherosclerosis, a lot of the same stuff happening. You get fat, you get inflammation, and you get fibrosis. Many of the same things that you see. So in some ways, a lot of the biology of the liver is recapitulated in atherosclerosis. A lot of the biology of atherosclerosis is recapitulated in the liver. And we know over here, we showed some, now this is over almost 15 years ago, that despite it's not just triglyceride, every class of lipid is increased in the liver. So despite accumulation of cholesterol, your HMG-CoA reductase, which is the rate-limiting step for cholesterol synthesis, is increased in these patients, which is shown through gene expression. And this level of gene expression is also linked to LDL cholesterol. And we also show that desmosterol, which is a biomarker of hepatic cholesterol synthesis, and the liver actually makes the bulk of your body's cholesterol. Cytosterol is a marker of dietary absorption. You actually see these patients, this hypercholesterolemia and LDL cholesterol driven largely by increased synthesis. So all of this has led us to this construct where we go from healthy to metabolically unhealthy, largely driven by excess adiposity and adipose tissue inflammation and a state of metabo-inflammation throughout the body, which then affects the individual organs in different ways. And it goes through a clinically silent phase till that organ is sick enough that it is clinically obvious. So if you are a cardiologist, you say, oh, my patient has cardiovascular disease. If you're a diabetologist, you say, now my patient has lost all their islets, they have developed hyperglycemia. If you're a kidney guy, you'll say, now my EGFR is below 60, they have CKD. And if you're a liver guy, you'll say, oh my gosh, now my patient has got cirrhosis. But what we forget sometimes, we're talking about the same patient. The same guy that the diabetologist is talking about, the same guy the liver guy is talking about, they're all talking about the same patient. So we need to think about this in a more integrated manner, and hopefully I've provided you a rationale for why we need to take a more integrated approach to this. So now that we first talked about the scope of the problem, we sort of provided this more integrated concept, but from that integrated concept of metabolic health, and through what we learned through this journey that we took trying to understand this liver disease, how we're beginning to sort of see how to integrate the liver care, going from organ-based approaches, which is one organ at a time approach, to what we like to call metabolic medicine. I don't like the word, you'll see a bunch of publications with this alphabet soup of C, K, L, M, R, depending on. And, it always, first of all, you don't know what the right sequence is. Does the sequence mean something? Does C mean that the C is a bigger guy and a better guy and a more important guy? And the guy who is later in the sequence, their disease is not so important? I think that leads to asking bad questions. Then it certainly becomes a question about whose specialty is more important, which doctor is more important. But this is not about us. It's about our patients and about the patient's health. And for the patient, all of it is important. That's why I like the word metabolic medicine, understanding the root cause of what is actually going on over here. So just present three concepts. One is MAS. Just ask yourself three things when you're seeing this patient, because in case you're thinking, oh my God, I already have to take care of so many things when I'm seeing my patient. in that very short period of time I have in clinic. Now you want me to figure this whole thing with new organ disease? So let's try and make this simple. 3 simple steps. Is the disease present? Is intervention needed? And if so, what interventions and how I'm going to follow the patient after I intervene? This is actually a general rule of medicine for pretty much everything we do, right? So let's ask, is MASLD present? So where we've come to is this holistic view of MASLD, where a combination of genetics, there are some genes that make you more prone to having liver disease, nutrition, insulin resistance, alcohol, diet, exercise, environmental pollution, all of this come together to create that milieu in which you start getting excess adiposity. From a liver part of it, there's one axis. You go from steatosis, steatohepatitis, fibrosis, cirrhosis, liver outcomes. But at each step, there are competing threats from cardiovascular disease, neurocognitive decline, vascular disease, glycemia, chronic kidney disease, cancers, etc. So keep that in mind. So to ask that first question, is MASLD present? Does a person have excess fat in the liver? Well, what we know is that if you actually just look at the clinical profile of the patients, if you have 2 or more features of the metabolic syndrome, which you should be able to look at the patient and pretty much tell, you can tell what the pre-test probability or your a priori likelihood of having excess fat in the liver is. So you, even without doing any tests, if you just said, oh, you got fat in your liver, you'll be right way more times than you'd be wrong. So I think for me, if a person has multiple features of metabolic syndrome, I just assume they're going to have some excess fat in their liver. And turns out even 12 to 20% of lean individuals who have other metabolic risk factors may also have excess fat in the liver. So if somebody's lean, don't think they're off the hook per se. Okay. So the bigger question is not whether there's fat in the liver, which most of our patients have, but is this hurting the patient? Do I need to do something about it? Do I need to worry about this? So this is the algorithm that the American Diabetes Association put out this year. So what we did when we were looking at this, again, right up front, we realized that if you have obesity with 1 or more cardiovascular risk factors, you have type 2 diabetes or pre-diabetes, you're already very likely to have excess fat in the liver. So we want to make sure in this population, don't forget there are few other, especially if the person has abnormal liver enzymes, that you can have abnormal liver enzymes from other things. So I'm walking you from the left to the right of the slide. Get a hepatitis C and hepatitis B if you are not doing it already, and then you're out of compliance with the CDC guidelines, and it might be good to get in line with them because they are treatable, highly treatable conditions. And hepatitis C is curable. Also ask question about alcohol. We are now increasingly using a test called the phosphatidyl ethanolamine, so identifying really significant alcohol use disorder. And then, of course, once you do that, if all these are negative, safe assumption that everything is being driven by the metabolic dysfunction. So then we test something called a FIB4. FIB4 stands for fibrosis 4. It's a formula based on age, AST, ALT, and your platelet count. And if you take out your cell phone, you Google FIB4, you'll see a calculator pop up. And if you put in your own age, those of you who can go into your My Chart and pull up your AST, ALT, and platelets, plug in your age, AST, ALT, and platelets. You'll get a number. If that number is less than 1.3, your liver is in awesome shape. You're in no imminent threat of anything from a liver, at least in a 5-year time horizon. But if it is more than 1.3, then that means it's likely that your liver is starting to scar down. If it is over 2.6, which is another step, double of 1.3, you're highly likely that you have advanced fibrosis or maybe even cirrhosis and you just don't know it. So check that FIB4. All you have to do is make sure when you get a CBC, you order platelets with it. Make sure you get the CBC with the platelets. And you get a comprehensive metabolic panel at that annual visit, which should have AST, ALT in it. That's it. You can compute your FIB4. Those of you who use Epic, you put in .fib4 and it'll populate it for you. It'll do the background calculation for you. And more of these EMRs are doing that. So fib4, so easy, do it. If it's more than 1.3, then we go to secondary testing, and often that is done with elastography. If it is low, you repeat fib4 every couple of years. If it is high, then you go for secondary testing. If it's more than 2.6, that's the patient you probably want to refer on to a gastroenterologist or a hepatologist, because they're likely to already have advanced fibrosis or cirrhosis. Okay. So this is really fib4. Coming back to fib4, is widely available. It's a surrogate for fibrosis. It is associated with prognosis, and changes in fib4 further linked to prognosis. So these are linked to outcomes in the general population as well as in disease population. So these are data from another study we did, which is a community-based study, and which shows that basically as you go from fib4 less than 1.3 to the intermediate zone of 1.3 to 2.6 to greater than 2.6, there's a progressive and exponential rise in mortality, liver events, MACE, and liver cancer. So fib4, that very simple thing that you can do in your test, if you do nothing else, if you take nothing else away from this, could just do that fib4 and use those 1.3 and 2.6 as triaging rules to decide what you want to do with the patient. Now, beyond the fib4, once you get that fib4 of greater than 1.3, we will often do something called a fibroscan, which is an ultrasound-based, it's an elastography measure of how stiff the liver is. So the more scarred your liver, the more stiff it is. And what we showed over here in this big cohort study is that if your liver stiffness stays below 10, so on the left-hand side, you're looking at people who started below 10 as the kilopascals, that's the marker of elasticity, and stayed below 10, low levels of liver outcomes, jumps, only most of the outcomes occurred in those whose liver stiffness progressed. On the right-hand side, you're looking at those who basically started above 10, and some of them improved over time, and those who improved, in the orange bars, you can see had a much lower likelihood of having an event. So 10 is this magic number. If the liver stiffness is below 10, you're in good shape. If your liver stiffness is above 10, then you have a problem. And then the higher it is, the more of a problem you have. And we have this simple rule of fives. So 10 is your magic threshold. 15, we start worrying about cirrhosis. 20, we are getting more certain about cirrhosis. And then above 25, it continues to, you get portal hypertension, all the ascites, bleeding, all kinds of other badness. So simple rule of fives. So remember, fib4 followed by if it's more than 1.3, get that fibroscan, do the fibroscan. Less than 10, you are okay from a liver point of view for now. More than 10, rules of 5. And every rule is an ordinal step up. So going from 5 to 10, 10 to 15 is not the same as going from 15 to 20 or 20 to 25. It's an exponential increase in risk. So these are ordinal steps. Okay. And what we have done is we've developed a way to visualize this so we can have this conversation with our patients. So I love the traffic light. Patients understand green, amber, red. We all sort of have lived by this every day. So what we do is create a target. And essentially the green is the safe zone where you're doing okay. Orange means pay attention, start doing something. Red means, wow, you have a big problem. You need to do something right away. So we use these fib4 cutoffs and the LSM cutoffs. Similarly, you can develop thresholds for cardiovascular risk, diabetes, etc. So you can basically start counseling your patients where they are over time. So then the last piece is how do we manage these patients? So the first question is, if you look at the population pyramid of this population, most of them are at the base where they have very early stage disease. Remember, their primary threat to life is cardiometabolic. So the question is, will elimination of steatotic liver disease, if you just get rid of the fat, will you prevent progression? So we always follow life's essential aids. You could have different versions of this. ADA, every society has its own guidelines, which is some version of this. So I don't care as long as you're doing all of these in some way. Okay? But then this is very interesting. So as we live in this era of really incredible pharmacological development for obesity, and these are data for retatrutide. And what we showed here is, first, you have Anya Yastrebov's data showing that at 48 weeks, you have this 24% weight loss with Reta. But when we looked at those who had excess fat in the liver in this study, what you see on the right-hand side is that up to 86 to 90% of these patients completely wiped out the fat. There was no more fat that could be detected by MRI, which is the best and the most sensitive way of detecting excess fat in the liver. So we now have to see whether if you knock out the fat, liver enzymes become normal, will this person never develop liver disease? We think so, but time will tell when we have data. Moving on to the next strata, when you've started scarring down your liver. So at stage 2 onwards, your liver risk starts going up. And that's why that's the strata which is now recommended for pharmacological treatment with liver as the target. So they are called at risk. So it's not at risk for MASH. That's not exactly correct. It is at risk MASH. It is there at risk for outcomes. They're not at risk for MASH. We already know they have MASH. So these are people who have fatty liver disease. They have high activity. They have started scarring down their liver. So that's the definition, at-risk MASH. Steatohepatitis, histologic activity score greater than 4, fibrosis stage greater or equal to 2. So typically, this is your patient whose FIB4 is 1.3 to 2.6, and the liver stiffness is between 10 and 20 kilopascals without thrombocytopenia. Because sometimes if you have thrombocytopenia, there could be some patients with cirrhosis in there. So, okay. So in this setting, we now have our first drug approved for this disease, and this is resmetirom. It is a thyroxine beta receptor agonist, which is different than regular thyroxine because it's only liver targeting. Beta receptors are in the liver. And it causes the liver to oxidize fat. It turns over mitochondria. It creates healthy mitochondria and reduces oxidative stress in the liver. And basically, it produces improvement in fibrosis. Remember, fibrosis tells us proximity to cirrhosis. And because it tells us proximity to cirrhosis, it's the most important prognostic biomarker. So we really want to see improvement in fibrosis. So this is the basis. Now, this is an ongoing study to outcomes. It also reduces LDL cholesterol, and we're waiting to see, if it also improves cardiovascular outcomes. There are classic studies with classic insulin sensitizers because insulin resistance is at the base, with pioglitazone and vitamin E because oxidative stress is part of the liver injury, and they have modest benefits as well. And they are certainly for those who cannot afford the other drugs. This is a possibility. And then, of course, the big one in the room is GLP, which all of you know has so many different biological effects for obesity and metabolic benefits. But in the liver, it improves triglycerides, inflammation, and glucose metabolism. And all of these effects are mediated by its effects outside of the liver because there are no GLP-1 receptors in the liver and hepatocytes per se. And these are the data from the semaglutide phase 3 trial, which show, we just published this a few months ago, and shows 62.9% resolution of steatohepatitis compared to 30% in placebo, 30% regression of fibrosis in people who had fibrosis stage 2 or fibrosis stage 3. This was the basis actually for continuing forward. And you can see over here, along with improvement in body weight compared to placebo and resolution of steatohepatitis, as well as improvement in fibrosis, and then, of course, showing decrease in body pain. And this was now very recently approved, FDA approval for non-cirrhotic MASH with moderate to advanced liver fibrosis in conjunction with reduced calorie diet and increased physical activity. Right behind it, there are other drugs which are GLP anchored. Survodutide is a GLP glucagon coagonist, and these are data we published last year showing that up to 83% MASH resolution and you're getting up to 60% fibrosis regression with survodutide. It's in phase 3. And the new kid on the block here really are the FGF21s, which is another class of molecules which have really very potent antifibrotic benefit. And 75% in this phase 2 trial of efruxifermin, which is a FGF21, 3 out of 4 patients reverse their fibrosis. So this is really quite phenomenal, 75%. And then when we get to the top, again, these are people who have a FID4 over 2.6, LSM over 20, or a LSM over 15 with low platelet counts. There's another test called the Enhanced Liver Fibrosis Test, which is also available through LabCorp. It's approved by the FDA above 11.3 as a prognostic biomarker. And in those populations, if you use efruxifermin, we now have data that it significantly reverses cirrhosis. So even when you progress to cirrhosis, you can turn the ship around until you get to a tipping point where the patient is beginning to decompensate. So over the last 10-15 years, we made tremendous progress with the treatment of MASH. And of course, bariatrics still has a role in carefully selected patients. These are data that we published earlier this year with Amin Ali, who is the primary author from Cleveland, and showing that you decrease major adverse liver events, or MALO, with metabolic surgery in compensated cirrhosis, less decompensation going from compensated to decompensation. And while we used to worry about sarcopenia in this population, this was not an issue, at least in this study. So where we have landed is that for all of these patients, you have lifestyle intervention with diet, physical activity, sleep, mental health, comorbidity care for all. So if you're, depending on whatever lens you're looking at the patient, you look at all your comorbidities. From a liver perspective, I've shown you sort of both a bottom-up approach where you focus more on the metabolic basis because their immediate threat to life is metabolic, and then, of course, top-down. And for those at the very top, there's a whole step of additional things which you may or may not want to do, refer the patients. But certainly we do HCC surveillance. For hepatocellular carcinoma, there's specific vaccinations. You evaluate portal hypertension and you treat it. You do band ligation of varices if they're present, and you monitor for transplant, etc. So in conclusion then, MASLD and MASH arise from interconnected mechanisms of obesity, insulin resistance, chronic inflammation, and genetic susceptibility. The guideline endorsed in non-invasive tools enable us to identify these patients even in our regular everyday clinics. And dual and triple hormone receptor agonists show promising effects on weight, glycemic control, and histological improvement. And incretin-based agents are reshaping care, offering potential to address both the metabolic and the liver fibrosis disease. And integrating these with lifestyle intervention supports personalized management and improved long-term outcomes. So I'll stop over here. Thank you very much for your attention.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, the Obesity Medicine Association. This activity is supported by an independent medical education grant from Boehringer Ingelheim Pharmaceuticals, Incorporated. To access all materials for this activity, visit peerview.com/GPQ860.